Yeah. I just was wondering, when you think we're all going to be able to have our own genome sequence so that you can, build your model. How far away are we from individuals as a standard practice?
Yeah, so I'll repeat the question because it's a little bit tough to hear. But the question is one that we all want the answer to, which is when can we use genomics in the clinic for every patient? The short answer is we don't have it yet, but we are actually doing it already. We have multiple protocols where basically every sample that we collect at the University of Miami is going towards a whole genome sequencing study. The pace is a little bit slower because it's all for research purposes, but the idea is that everybody that participates in a clinical trial, everybody that goes on a surveillance study is going to have their genome sequenced and will hopefully have this information conveyed back to them. As to when this is going to happen, clinically, where somebody out in the community can just order a test and you get a readout, it's a little bit further off. But as the cost of these things comes lower and as the computational powers of all of our computers are basically improving, it's happening pretty fast. And there are a couple of groups, for example, University of St. Louis is already doing it for leukemia, for example. So sooner than later, it's going to happen. It's going to come to a facility near you.
I would like to add to that. So I agree with everything, of course, Ben said. So what of the strategies that we are kind of coming up with at the University of Miami? So I worked very hard for the past 12 to 24 months to see how we could set up a collaboration with a strong partner that can generate the data in real time. So you can purchase these technologies. The price has also come down a lot, I should say. You could purchase the assay, you could take the sample, and you could sequence the sample. 5 years ago, to do whole genome sequencing for one sample was about $8,000. So if we were to do that for every patient that come to us, I would have to have $8,000 available every time I sequence and pay for it because it's not reimbursed by insurance. So I have a lot of donations from philanthropy that support the program, and I'm constantly working to write grants. All the time we are submitting grants because it costs a lot of money to drive innovation. The good thing in this context is that the price goes down a lot. So you can do this sequencing now for about $2,000. And the competition is good. So Illumina has been the driver. There's another company that's also pushing for it. They are now saying we can do it for $200. So, and then the other company said we can do it for $100, and now they're talking about $60. And we love all this. So we had invited for New York Genome Center the other day. One of the leaders, we work closely with Dan Landau from Cornell. We were in New York. Ben and I were, and Arjun, we all were in New York before. So we are members of New York Genome Center, probably for life. We're never going to stop being members there. So we work closely. So we have the Ultima, which is the competitor with Illumina, and they are fighting with each other, which is great. They're driving down the cost. And we have access to these technologies. So that's the one side on the research side. But what I've tried to do also for the clinical side is to find a partner that can do it so we don't have to do it in real time because it's a lot of responsibility for us. So there are now companies that are starting to generate FISH results using sequencing. So if you sequence the genome, if you know how to analyze it, you can get the same information out of it as you would do with FISH and cytogenetics, plus that you have all the sequencing data. And they don't really know how to analyze all that. So I've set up legal agreements with companies. We can send the samples there. They will generate the data. It will replace FISH and cytogenetics, plus that we get access to all the raw data so we can do all the discovery. So that's going to happen in 2024. And in 2025, I hope that these companies will go from whole exome to whole genome. So it's part of a strategy for us to be able to basically outsource the sequencing to someone else so we don't have to do all that heavy lifting. We get information that replaces FISH and cytogenetics, and then we can get all the raw data back so we can generate databases for discovery. So this is a hot topic for us. It's really a priority. And you heard me talking about this, the blood-based technology. What I ideally would like to do is to partner all this information with the blood-based technology and see if I can get the same information out of the blood. So that sort of will be the 2.0 version. So that's what we're going to do.
Amazing. Okay.
Hi there. I'm wondering, does whole genome sequencing have to be done upon diagnosis, and does it ever evolve over time? And then a separate question, completely separate, with venetoclax, if you have a patient who has T1114 and is thinking about going on that, is it worthwhile to test for BCL2? Is that ever done prior to putting them on venetoclax?
Let me start with the genome sequencing. So the short answer is no. You can do it at any time, but the limitation is that you want to make sure that there's actually cancer there to sequence. I mean, if you're in a very deep remission and there's no cancer, then we have nothing to sequence. There's no DNA. So you can do it at newly diagnosed setting, right, which is basically what we're building that model on. You can do it when the smoldering disease, right, and we've done that as well. And then you can also look at relapse. And that's important too, because the disease definitely changes over time. You give it one therapy, eventually the disease will relapse, and there might be some new mutation that caused that relapse. And we are definitely actively investigating that, because the kind of relapse that you get, the kind of mutations that show up at relapse probably matter for selecting the next therapy that we're going to go on to. So yes, the answer is yes, we will test it at multiple different time points depending on the question that we're trying to ask. As for the venetoclax, I don't know if you want to take that one along.
Yeah, so for venetoclax, there is data showing that activation of BCL2 is obviously critical, because venetoclax is a BCL2 inhibitor. So BCL2, which is a gene, is a pathway that the myeloma cells may depend upon. If that is an active pathway in that given patient, you can use that as a target. It's about 10 to 15% of patients in the United States with myeloma that have that particular pathway activated. So 11, 14 translocations, if you do fission cytogenetics, many patients that have an 11, 14 translocation have that pathway active. It's not exactly the same thing, so it's sort of a surrogate marker if you want, but because fission cytogenetics is available most places, people use that as a surrogate marker. So your question is, could you run a test that looks for BCL2 activation and find that to be active even in individuals that don't have an 11, 14 translocation? And it's not really an established way to do it. There is no validated test, but you could, on a scientific note, find that there are cases like that. And you could also see in patients who have an 11, 14 translocation that some patients have a very high BCL2 activity, some have a much lower, and some of them actually don't have really very much going on. And that probably is part of the reason why venetoclax work in some patients very well and maybe a little bit less well in other patients. There's sort of a heterogeneity there. I think the full answer will be when we are pushing forward, as you heard from Dr. Diamond, when we are pushing all the way through with precision medicine. If we have full characterization of individual patient's disease, we can much better tailor the treatment to that very disease. And that's what the IRMA model is about. That's what we're going to keep on pushing, and that's part of the mission along the lines of what I said before with the pipeline we are setting up for profiling of disease.
Okay, question here.
On the topic of genomics, you hear a lot about 17p, but also it seems that attached to that, there's p53, if you could talk about that. And then 1q, we hear gain versus amp. Does the number of copies, extra copies of 1q matter? And in the immunotherapy talk, I didn't hear anything about cell mods, if you can address that.
Okay, we'll try and address all of them.
You want to do all of them?
Sure, why not? So the first question is actually a really good question, and it helps us differentiate between FISH and genomics here. Okay, so you asked about 17p and TP53. So we have a probe in FISH that looks at a region on chromosome 17 on the short arm, specifically where p53, the gene, is housed. All right, all we can do with the probe is see if this region is deleted. Okay, so the deletion could be multiple megabases big. And you don't even know what else is deleted in that sequence, right? But you can detect the presence or absence of this, and we presume that the gene that we're trying to detect, which is p53, which is considered the guardian of the genome, right? If it's deleted, it's a bad thing. Now, when you use whole genome sequencing, not only can I tell that the specific gene is either mutated or deleted, or there's a variant that causes it to be shattered and combined with another chromosome, you get so much more resolution. And then, if there is a deletion on 17p, I can see what else was deleted, all right? Not just the TP53. So the short answer, yes, is that they're kind of, one is a marker of the other, but the more specific test that we're interested in is the TP53 deletion itself. And it technically is seen to have a high-risk presentation because of that nature of it, that it's a guardian of the genome. There's more instability when you lose it. As for 1Q, yes, the number matters. You'll see some data that's actually going to be published sometime soon. The short answer is that the more copies that you have, the worse it is. So amplification implies that there are 4 copies of 1Q or more, whereas gain is just 3 copies, right? So 1 single gain. And people with 4 or more do worse. There's going to be, like I said, a publication that comes out that says, just to make it even more complicated, that the time in which you acquire that gain matters more than the number of copies. Okay, so that's another feature that can be determined with whole genome sequencing. You can actually time when exactly in your life the event happened, and that matters. And then finally, the question was on CELMoDs, a really promising area of drug development. We have the IMiDs right now, which have their own mechanism of action. They kind of modulate the immune system. But to try to get around the mechanism of resistance and to bind tighter the target that they're trying to go after, which is cereblon, which is where CELMoD comes from, you can actually bind tighter, cause more activity, even in resistant cells, and potentially have a stronger response. And so they're currently evaluating the drug in multiple different settings, in multiple combinations, and even post-CAR T as maintenance, for example.
Maybe I would like to add briefly to what Ben said. He gave you all the details for this 1Q and 17P. When you do fission cytogenetics, the report would say 17P deletion, 1Q gain. And you heard from Dr. Diamond, there's so much more information that the FISH report doesn't capture. So in a very simple way, if you have a 17P deletion, as Dr. Diamond just said, we are all born with 23 chromosome pairs. For each chromosome pair, there is 1 allele from our mother, 1 from our father. That makes up the 46 chromosomes we have in every cell in our bodies. In someone who has myeloma, those cells look very similar to the healthy cells, but there are some mutations that they have in addition that makes them myeloma. On that 17th chromosome, if one of the 2 short arms has been deleted, meaning there's a piece fallen off, the FISH probe can see that. If it has happened, if it works, the FISH, it will tell you that. But it doesn't tell you all that other granular information. So what has been found is if one is missing, it does actually not matter. And if it's missing and the other one is inactivated with a mutation, now none of them work. And TP53 was discovered 30 or so years ago. It's a tumor suppressor gene. Dr. Diamond said it's a guardian of the genome. I think elephants have, do they have 12 TP53 genes or something? They have a very large number.
Yeah.
Elephants don't have cancer. Humans, there is a weakness in our construction. We only have 2 TP53. So if one of them is deleted and the other one is mutated, they don't work. TP53 is a very common Achilles heel in cancer. For more aggressive cancer. So if both of them are inactivated, that's very different from having just one of them. So on a practical note, if you have 100 patients that worked up with FISH, cytogenetics, and they all have 17P deletion, we have found that around half of them have mutation on the other allele, and half of them don't. So if you tell that patient you have high risk, you lie every other time. That's exactly what I said before. You heard me saying, it breaks my heart when someone comes and tells me, I'm here today, I've not had a relapse for 10 years, but how could that be? I have high-risk disease. It's because you don't have high-risk disease. So that's an example of this same thing. And 1Q is exactly the same. So FISH and cytogenetics is like watching black and white TV, while what we are talking about is like 8K or 16K high-def color TV. So we just don't want to do FISH and cytogenetics. We would like to stop doing it as soon as possible. And if these companies can sequence for $60, we're going to start doing it right away.
Okay, fantastic. What other questions does everyone have? Can I ask a question also? Well, I want to ask a question too, and then we'll take your question. But about sequencing, how do you look at treatment sequencing when we have the bispecifics and CAR T and CELMoDs coming, and and. It's a wonderful abundance of blessings that we have. But how do you, especially when you're thinking about this personalized method of treatment, how do you think about treatment sequencing?
You want to start with that one? You want to start with that one?
Sure. Yes, so I think the correct answer is that no one at this time knows what the optimal sequence of therapy is. That's true probably for any therapy. So if you ask about bispecifics and CAR T-cell versus CAR T-cell and bispecific, it's a very common question. I think the jury is still out. If you look at the studies, some of the trials for bispecifics allowed patients to previously be exposed to CAR T-cells. And when they looked at the results afterwards, those patients who had a prior exposure to CAR T-cell with the same target, they were not that different. They were a little bit less good responses. Same way, if you look for the CAR T-cells, some of them allowed patients to have been exposed to prior antibodies bispecific with the same target. There were responses. They were a little bit less effective in those patients who had a prior exposure. So if you put confidence intervals around this, because confidence intervals mean how sure you are. If you have 100,000 patients worked up, the confidence interval will be very narrow. But if you only have 20 patients, the confidence interval is wider because there is a lot of uncertainty. So if you look at the confidence intervals, they're quite wide because the studies are quite small, actually, and there are too few patients to give a definitive answer. So if you look at it and say, is there a difference statistically between those CAR T-cell with prior antibody or antibody with prior CAR T-cell, I think the formal correct answer is that there is no statistically significant difference, but it looks like maybe a little bit less good. Now, if you put time into the equation, that gives you a very important additional piece of information. So a patient who was given antibodies, and you got this once a week, maybe every other week, and you continued for a long, long time and benefited, say, from BCMA targeted bispecific. And eventually, unfortunately, say it stops working. If you next month go to a CAR T-cell for the same BCMA, that is going to work less well compared to someone who went to another therapy with another mechanism of action. And say 6 or 12 or 24 or whatever months later went to that CAR T-cell with BCMA. That's going to work very well. So time is very important. And I think it's not different from many of the other drugs we use. Say you use daratumumab, and it works very well. And eventually, unfortunately, it stops working. If you go right to isatuximab, also CD38 targeted antibody, it's probably less likely to work. But if you went to another therapy, and you got good mileage out of that, and that eventually, unfortunately, stops working, now you can go back to isatuximab, and it's very likely to work well, and vice versa. So I think what we need to do is to learn more about how they work. And in addition to this, there is also a lot of discovery we have done, and I will hand over to Dr. Diamond to talk about the discovery that we have done in collaboration with other groups.
Yeah, thanks for handing that out. So it's a really good overview, and it's true at this current point in time, we don't really know what the optimal sequence is, but genomics can definitely help us figure that out. There was some work that our group did in collaboration with Calgary, really, really elegant work that's published in the Nature Medicine journal, basically showing that a lot of patients that actually get these bispecific antibodies have a genomic mechanism for relapse. So for example, let's say teclistamab is given or elranatamab is given. A mutation can develop in the binding domain. So exactly where the antibody tries to connect to the cell, you can get a mutation right there. And that's what causes the relapse. I mean, the antibody can't bind there anymore, and now the myeloma cell can grow. But in the lab, what we saw was that those mutations actually don't preclude you being treated with another BCMA-directed target. You know, BCMA is still there. It just has a single mutation that's causing the antibody to no longer bind. And they showed that using a different antibody or using a CAR T-cell therapy could actually bind that mutation. And so that's why this is important, because when you look at a trial level, you can't really tell who these people are. You don't know what they did to have a relapse. You don't know what mutation there was, if the whole gene was lost, or if there's a single mutation. But if we know, right, then we can actually choose the next line of therapy with an educated manner. We know that we can use another BCMA-directed therapy versus having to switch to, say, a GPRC5D or an FCRH5. We need that precision medicine to be able to do this, and we are working on ways to accomplish that, both with invasive genome sequencing, looking in the bone marrow, and also looking at cell-free DNA in the plasma to see if we can cut down on the number of bone marrow biopsies we need to do.
Okay, well, maybe we need to invite patients to give you a bone marrow sample so you can run all those tests, right?
Can I ask a question to Arjun? Because
Sure.
Arjun has
Yes,
worked on the
please.
precision medicine. So Arjun, we showed here the IRMA model, and it's based on all the existing treatments that are out there. So could you say something about how IRMA can be used for future treatments as there will be new therapies developed? Can IRMA include those data sets? Could you talk about that a little bit?
Yeah. You guys hear me okay? Anyways, thank you for the opportunity for sharing the stage with folks here. My background is in computer science, just to give folks a perspective. I worked in AI, machine learning prior, and I worked at Sloan Kettering doing cancer research for about 10 years now, I think. So when we first started our journey in cancer research 10 years ago, AI was there, but it was not visible to the public. And one of the things of interest at the time was precision medicine. People were talking about it. But there was a bit of a disconnect between the technology side of things and then the medical side of things, because people were in silos. So what's happened, I think, in the last few years is, and that's one of the things that attracted me towards working with Ola and his team, is fantastic future thinking, where they actually were able to put together a data set which was so complex, because there's all these confounding effects, right? Like patients that are old can't get transplant, for example, because they're frail, etc. But that's a bias in and of itself in the data set. So teasing out these things and building a proper cohort, I think this is something that has not been achieved really in the field. So, and AI, what it is today, and folks have used ChatGPT, I guess, so very familiar. So in a way, you can think about it as a ChatGPT, but I think it's a bit more sophisticated than that, because the data set is so well put together, but it's so complex in variety of things. So one of the things that we talked about, I think, was the size. Like the number of samples matter, because each patient is different, and there are certain things that are very similar as well. So we need to understand maybe in a data-driven way, because a human being can't learn a lot of these patterns looking at different patients. Maybe a good physician over time learns them, but then you can't look at more than maybe a few 100,000 patients in your lifetime, really. So that's what inspired us towards AI, really, is it was at a good point where the genomic side, treatment side came together with the AI as well. And we were able to put together. And as far as the number of samples and treatment is concerned, like Ben actually mentioned and Ola's mentioned, sky's the limit in this, because the more samples you add, the better the model gets in understanding what progression means, right? That's what the model's trying to figure out. It's not necessarily that you do better or he does worse. It's really trying to just understand the disease itself, because we have like genome-wide information now, not necessarily just like clinical information. So much deeper information, much broader information. So I guess the future is pretty bright, because in the next few years, I think the model's going to get the latest therapies, right? That's very important. And I think that will change what IRMA is going to look like from today. If people haven't used the website, I think I encourage you, because it's still in research. It's not out there for, understanding the disease, but it's a good tool for you to use.
Okay, the work you're doing is just fascinating. Okay, I know there are some smoldering myeloma patients and MGUS patients in the room, so please consider asking a question about that topic while we're hearing about this question.
Yeah, I'm just curious. I think I've already heard the answers before, but is there a chance that you could go off maintenance? Say you're doing pretty good, all the numbers say good. Just go for a yearly checkup, get to that point where once a year you go in, just check yourself out, and you can go live your life, travel, and be snowbirds or whatever you want to be?
I think that's an excellent question. And I think if you look at what's known and what's not known, I think, in my opinion, correct answers are we don't know what the optimal duration of maintenance therapy is. No study has definitively answered that. If you look at parts of the world where they don't have funding to support continuous maintenance, in Australia, I spent a lot of time, I've traveled many places, I've been in China, Japan, New Zealand, Australia, giving talks. Many of those countries, they do 1 year maintenance and then they stop because they cannot afford. Europe used to be the same.
So if you look at their data sets, 1 or 2 years of maintenance, what happens? Well, any patient actually could have years without having recurrence. But also if you compare to American data sets where you have continuous maintenance, there is a difference in the median progression-free survival, meaning that the disease stays away longer if you do continuous maintenance. And that's how lenalidomide was filed to the FDA for continuous maintenance and then made it into the guideline. But some patients can be off for a long time. Some patients could be off for a few months, some patients could be off for a year, some people could be off for 2 years, some people could be off longer. Now, I think it's also is a matter of the disease biology and also what type of treatment you get up front. So I mentioned the MASTER trial in my presentation. They used the DARA KRD, which I think is the most powerful therapy we have out there at the current time for newly diagnosed treatment. So daratumumab, carfilzomib, lenalidomide, dexamethasone. They gave for up to 12 cycles with a transplant. And they showed when patients were off therapy for 3 years that 85% of those patients still had no progression event. I think what's going to happen is that more and more patients will ask these questions, and I think it's going to be, in my opinion, driven by what I just said. It's going to also be driven by CAR T cells, because they're now coming for the first relapse, already approved. And CAR T cell is a one shot, and then you're off therapy. So you don't have to sort of preach something new that has not been done in the field. People are off therapy with CAR T cells. So many times when you come with new ideas, a lot of people are pushing back and say, no, don't do that. But CAR T cell is sort of helping it. I also think that the technologies with monitoring in the blood, if you go off therapy and you can safely monitor a blood-based MRD test, I think will be one of the main vehicles for this to happen. So we have on this MRD meeting, I showed on my talk, the last slide I had on May the 9th, the MRD meeting, we have invited 4 speakers. The updated MASTER trial, the one I was just talking about, the updated Sloan Kettering trial that Ben and I actually wrote the protocol for, is still ongoing at Sloan Kettering. The University of Chicago trial, and the UK 11 trial from Europe. Those 4 trials are all testing the question you're asking. What happened if you stop therapy? And they monitor patients for many years. So tune in on May 9th online, and you will hear from 4 different studies what they show. That's the best answer I can give. I don't know if you want to add to that.
There's not much to add to that, to be honest, yeah.
Okay, great answer. What other questions?
This is maybe off subject a little bit, but I know the gut microbiome in the immune system, right? Your immune system lives in your gut maybe 60 to 70%. So there were some studies on butyrate and myeloma patients that have higher levels or lower levels, and then correlating that with Dr. Shaw, who talked about 30 plants a week for myeloma patients. Maybe that could do something to their gut microbiome that may help to stall the progression of disease. Do you have any opinions on that?
Yeah, I think this is a really interesting area of research, and I think it's a really important area of research because this is something that, as patients, we can enact change. All right, this is something that we can take into our own hands, and I think that's what makes it great, is that it's empowering. Irvi's doing great work. She's actually doing work on some of the trials that Ola was discussing. Some of these maintenance trials is the perfect area to look at the microbiome and to look at diet, because these are stable patients that are on therapy, a single therapy, all the same therapy for a long time, and we can really look at the outcomes. So there's a lot of different ways to slice it. It does look like patients with this kind of butyrate-producing bacterial profile are the ones that sustain MRD negativity the longest, and that's a really nice prognostic feature. The problem is that we can't really, at least so far, figure out a way to modulate that to improve outcomes just yet. So it's still kind of in its early stages, but it does seem like it might be a good biomarker for MRD negativity. And to that end, we do think that research in this area is very important and should continue. And if we can find a way to modulate things like butyrate and probably a lot of other factors to try and make diet something that's a little bit more powerful and empowering in terms of impacting our disease, we're going to jump right for it. And I think this is the kind of research that really needs to be powered and funded and moved forward.
Okay, one other question that I have is how best can patients help you accomplish the research goals that you have set out? Because they're bold and they're innovative and they're really amazing.
So the question is how patients can help us. Well, I would say that we are here for the opposite reason. We are here to help patients. So I don't think patients should enroll on any of our trials just because. We are here, we are offering trials to help the patients. It's all about availability of options. We will offer all patients that come to us standard of care. We have all the standard of care. We currently have over 20 open trials, and we are about to open another 10 trials. We have a lot of first-in-human trials for patients who may have run out of other options. We have all the latest immunotherapies. We have them for earlier indications. We are taking all the drugs early on. We opened the REVIVE study. That's a bispecific antibody with naked antibodies with teclistamab with daratumumab for smoldering myeloma. We are partnering those two drugs with MRD testing and sequencing, and we are going to treat for 18 to 24 months with the goal to see if we can have 5-year MRD negativity sustained, basically a way towards a curative approach. We're going to keep on pushing for newly diagnosed. We're going to push also for all the relapse indications. That's why we recruited Damian Green here for CAR T-cell. So the patients are not here for us. We are here for the patients. And that's how it will always remain.
Yeah, I think we should give them all a hand. Aren't they incredible?